Sonographic cervical length for the prediction of preterm birth, standardization of the technique and pitfalls. I have no relevant financial relationships or conflicts of interest to disclose. The learning objectives for this lecture are the following: the definition of a sonographic short cervix, the gestational age at which a cervix should be examined, additional ultrasound parameters to assess preterm birth risk, the correct technique for the measurement of cervical length in pregnancy, the assessment of amniotic fluid sludge, treatments for a sonographic short cervix, and future methods to assess the cervix in pregnancy. We will discuss numerous things, including the definition of a short cervix, the gestational age at which a cervix should be examined, additional ultrasound parameters to assess the risk of preterm birth, the correct technique, including pitfalls that may occur for the measurement of cervical length in pregnancy, interventions to prevent preterm birth in women with a short cervix, and future methods to assess the cervix in pregnancy. Preterm birth is the leading cause of neonatal morbidity and mortality worldwide and results in the devastating complications of respiratory distress syndrome, chronic lung disease, bowel injury and inflammation, long-term mental disabilities, and cerebral palsy, which can be severe in nature, such as this child shown here. There are approximately 15 million preterm births worldwide per year. There are about 500,000 in the United States per year, and the highest rates occur in Africa and North America. In addition, the annual societal economic burden associated with preterm birth in the United States is in excess of $26 billion per year. Preterm birth occurs as a result of premature activation of the common pathway of parturition. This pathway includes myometrial contractions, decidual membrane activation, and cervical dilation and ripening. The stages of cervical ripening and function throughout pregnancy have been described as softening, ripening, dilation, and repair. We have used ultrasound in the softening phase to attempt to identify those women at greatest risk for preterm birth. To do this, we have used sonographic cervical length assessed by transvaginal ultrasound. We know that the risk of a short cervix for preterm birth increases as the cervical length decreases. This has been shown first by Dr. Anderson and colleagues in 1990, then by Dr. Imes and colleagues, followed by Dr. Heath and colleagues from the United Kingdom, and then by our group in 2000. Consistently, a short cervix is associated with a higher risk of preterm birth. Collectively, those studies, as well as others, have noted that a short cervix is the most powerful predictor of spontaneous preterm birth, as noted here with an 11 millimeter cervix. So what is a short cervix? The definition of a short cervix varies based upon a patient's risk for preterm birth. For example, the cervical length cutoff that confers a risk of 50% for spontaneous preterm delivery at less than 32 weeks is 15 millimeters in a low-risk population, those patients without a prior preterm birth. In patients with a prior preterm birth, this cutoff is less than 25 millimeters, such as shown in this image. In multiple gestations, this cutoff is also 25 millimeters. What are the causes of a sonographic short cervix? A sonographic short cervix can be considered to be syndromic in nature with multiple etiologies. These include congenital, progesterone deficiency, surgical or conization, acute cervical insufficiency, changes in the extracellular matrix of the cervix, intrauterine infection. In fact, the frequency of interamniotic inflammation and infection has been assessed in women in the mid-trimester with a short cervix who are asymptomatic. In those patients, the rate of interamniotic inflammation is 22%, and the rate of interamniotic infection is 9%. So at what gestational age should the cervix be examined? Some investigators have evaluated the use of cervical length in the first trimester for preterm birth risk assessment. When imaging the cervix in the first trimester, it is critical to define where the isthmus ends and the cervix begins, so as not to artificially lengthen the cervix and obtain an inaccurate result. However, even if an accurate measurement is obtained at this time, we have no intervention to apply in the first trimester to prevent preterm birth. However, increased surveillance could be warranted if the cervix is found to be short in the first trimester. We know that the best time to examine the cervix for preterm birth risk assessment is at 14 to 24 weeks, with the range of 19 to 24 weeks offering the greatest predictive value. Now let's review some additional parameters that are often used to assess the risk of preterm birth during transvaginal sonography. These include the cervical funnel, dynamic change, and amniotic fluid sludge. This image depicts the funnel. The cervical length is measured separately. A larger funnel is noted here. The shoulder and the length of the cervix are measured. And in this image, dynamic change is noted when performing this ultrasound. However, several studies have demonstrated that funneling and dynamic change have no independent predictive value for preterm birth after cervical length is considered. Therefore, cervical length is considered the best predictor of preterm birth. Amniotic fluid sludge is another parameter to assess the risk of preterm birth when evaluating the cervix by transvaginal ultrasound. This large amount of sludge is seen in a patient with a short cervix without dilation. Amniotic fluid sludge is defined as the presence of dense aggregates of particulate matter in close proximity to the internal cervical os. In asymptomatic patients with a prior preterm birth in the mid-trimester, 17% of patients have positive amniotic fluid cultures versus those that in 0% in those with no sludge. 63% of those patients with sludge had histological chorioamnionitis, 15% with clinical chorioamnionitis, and 60% of patients with amniotic fluid sludge in the mid-trimester delivered before 32 weeks, compared to 15% of those without sludge. 37% of those neonates were admitted to the NICU. This graph represents the frequency of spontaneous preterm delivery at less than 32 weeks of gestation, according to cervical length and the presence or absence of amniotic fluid sludge. Note that even in women with a short cervix, those with sludge, noted in red, 71% delivered before 32 weeks. In contrast, those without sludge and a short cervix, 29% of them delivered before 32 weeks. Similar findings are noted in patients with a cervical length of 15 to 25 millimeters. Thus, the presence of amniotic fluid sludge increases the predictive value for preterm delivery and should be used in conjunction with cervical length. So what is sludge? This image depicts amniotic fluid sludge that was obtained for evaluation. And when you look at this material, the sludge contents appear to be a substance with a pus-like appearance. This was found to be a polymicrobial substance, and it is also found to be a biofilm, which consists of bacteria embedded in an amorphous material and inflammatory cells. This image represents a scanning electron micrograph of a flock of amniotic fluid sludge. The bacterial cells and the exopolymeric matrix material that constitute a biofilm are shown in this image. Next, we will discuss the technique of conducting a sonographic cervical length evaluation and review potential pitfalls that should be avoided. First, let's look at the normal cervical anatomy. It's important to identify the internal and external os and the canal length. And on the right, you see a graphic that is also internal os, external os, and cervical length. We know that cervical length is the most important predictor of preterm birth. And you can see it here noted, and the funnel again is noted, but again remember the cervical length is the most important parameter. The methods used to examine cervical length include transabdominal, transperineal, and transvaginal. The transabdominal examination requires a full bladder. It also is known to result in a longer cervical length than that seen by transvaginal ultrasound in the same patient. This mean difference between transabdominal and cervical length can be as high as 5 millimeters as a result of the presence of a full bladder, which is required for visualization by transabdominal ultrasound. This is an example of a full bladder that is necessary for visualization of the cervix when doing transabdominal ultrasound. As you can see here, this is an artificially long cervix, again as a result of this large bladder. This is another example of an incorrectly taken cervical length due to the presence of a large bladder, which is obscuring the cervical length to be accurate. Transperineal ultrasound has also been used in the past for the evaluation of the cervix. It was developed before transvaginal transducers were available. If used, one should avoid the use of a pelvic examination before such a scan. It does allow visualization of the cervix, but it is more difficult to interpret. Dr. Meyer-Hugoven and colleagues compared transperineal and transvaginal ultrasound. They found that there was a strong correlation with the transvaginal measurements. However, there was failure to obtain a clear image in 30% of mid-trimester pregnancies and 19% of third trimester cases. Often the landmarks were obscured by bowel gas. So transvaginal ultrasound of the cervix is objective, it is reproducible, and it is the most reliable form that we can use to evaluate the cervix. In addition, it is found to have minimal discomfort with its use. The appropriate view of the cervical length should be done by transvaginal ultrasound with an empty bladder. A sagittal view should be identified. The appropriate sagittal view is depicted here, which is guaranteed after securing the internal os, the external os, and you see the cervical length can be identified easily in this image. Dr. Berger and colleagues have displayed recommendations for standardization of cervical examination. First, the flat internal os or isosceles triangle should be identified. Observe the entire cervical canal. A symmetric external os should also be visualized. And you should note an equal size and an equal density of the anterior and posterior lips of the cervix. In addition, 3 measurements should be recorded. The shortest length should be used for clinical purposes. The exam should last for 3 minutes at minimum to account for any dynamic change that may occur. You should also record the presence or absence of amniotic fluid sludge. Some pitfall images I will be presented now. This demonstrates the presence of a full bladder and how it can affect cervical length. On the left, you see a cervical length of 35 millimeters, and the bladder is noted here with the B, and it is full. In the same patient, after emptying the bladder, you see the real cervical length, which is much shorter at 17 millimeters, because this is the accurate measurement. An example of an ultrasound being performed with excess pressure is noted here. As the pressure is applied, the cervix artificially lengthens, so it is important to maintain a constant, accurate level of pressure to avoid artificially lengthening the cervix. This image demonstrates an unequal distance and density of the anterior and posterior lips of the cervix. The result is a poor visualization of the endocervical canal and an inaccurate cervical length measurement. In this image, the endocervical canal is not visualized. Therefore, no cervical length of accuracy could be obtained. This image demonstrates a dynamic cervix. It is important that the cervical length be measured and defined as the portion of the endocervical canal that remains closed. This depicts another example. Again, the canal can be counted as those that remains closed. A non-measurable cervix is identified here, in which the patient is found to be dilated. When diagnosed in the mid-trimester, these patients have a 50% or more risk of preterm birth. In addition, a bulging amniotic sac can also be visualized, such as this 2D and 3D rendering of the sac, rendering a very high risk of preterm birth for this patient. Please remember also to note the amniotic presence or absence of amniotic fluid sludge, as is noted in this slide. Several examples of amniotic fluid sludge variations. However, all of them have conferred that higher risk of preterm birth, histologic chorioamnionitis, and risk for ruptured membranes. So we've shown that the prediction of preterm birth can be performed. But what about prevention? The treatments for a sonographic short cervix include progesterone, cerclage, and pessary. Progesterone has consistently been shown to prevent preterm birth in women with a sonographic short cervix. The 2 largest trials investigating this question were done by Fonseca and Nicolaides, and the second one by our group. We demonstrated that the use of vaginal progesterone in women with a sonographic short cervix reduced the risk of preterm birth by 45%, reduced respiratory distress syndrome, and improved neonatal morbidity. A meta-analysis subsequently performed confirmed a reduction. The use of vaginal progesterone in women with a short cervix was found to be associated with a reduction in the rates of preterm birth at less than 28, less than 30, less than 32, less than 33, less than 34, and less than 35 weeks of gestation. In addition, the use of vaginal progesterone in women with a short cervix was associated with a decrease in the rates of adverse neonatal outcomes, including an ICU admission, respiratory distress syndrome, mechanical ventilation, composite neonatal morbidity mortality, and birth weight less than 1,500 grams. So we've reviewed progesterone. What about cerclage? In patients with a prior preterm birth and a short cervix, should we use cerclage or vaginal progesterone? Dr. Condi compared the two interventions in an indirect comparison meta-analysis. He found that vaginal progesterone had a significant 53% reduction in the risk of preterm birth at less than 32 weeks, a 57% decrease in the risk of composite perinatal morbidity and mortality, and cerclage also had a significant reduction at 34% for the risk of preterm birth at less than 32 weeks, and a 36% decrease in the risk of composite perinatal morbidity and mortality. So vaginal progesterone and cerclage were both effective in these groups. One consideration when prescribing these things is the consideration of surgery versus medical treatment, and that discussion should be had. When assessing cervical length after a cerclage, it is important to assess the length of the cervix post-stitch. In this area here, this identifies the cerclage, and this is the area we are speaking about as post-stitch. In this image, number 2 identifies post-stitch. A cervical length of 10 millimeters or post-cerclage is preferred and is associated with an improved outcome of less than 10 millimeters. The third intervention is pessary. However, at this time, the evidence for the use of pessary to reduce preterm birth in women with a short cervix is not conclusive. Therefore, we do not recommend its use for that purpose. Twins are associated with a significant risk for preterm birth, and the rate is on the rise. The risk of use of cervical length and progesterone to prevent preterm birth in twins has been evaluated in a meta-analysis of individual patient data. In this meta-analysis, vaginal progesterone decreased the risk of preterm birth and neonatal morbidity in women with a twin gestation and a short cervix. Vaginal progesterone decreased the risk of preterm birth and neonatal morbidity in women with a short cervix. There was also a significant reduction in neonatal morbidity and mortality with the use of progesterone in women with a twin gestation and a short cervix. In addition, there was a very small number needed to treat to prevent these neonatal morbidities or mortality, and that range was from 6 to 8. In lieu of these findings we've discussed thus far, should all women be screened with transvaginal ultrasound for cervical length? Well, let's look at the practical consideration first. The practical consideration of time is how time-consuming is a cervical length measurement. This video depicts a cervical length assessment in our unit, and this is approximately 15 seconds. If it is even 1 minute or 2, then that is a time-efficient result. So how comfortable is a transvaginal ultrasound when it is performed? Well, Meyer, Hugoven, and colleagues assessed the pain score associated with different modalities of measuring the uterine cervix. The y-axis shows a pain score from 1 to 5, and the x-axis the percent response rate. Transvaginal ultrasound is noted in blue, transperineal in white, and digital examination in red. You can see that the pains associated with use of transvaginal ultrasound scored the least painful among those modalities used to measure a cervix. Dr. Coombs and colleagues have made a case for universal cervical length screening in this article. They have assessed it based on the 10 principles for a good screening test as proposed by WHO. First, the condition should be an important health problem, which we can agree that preterm birth is. There should be an available treatment, for which we have discussed the use of vaginal progesterone for treatment. There should be facilities available for diagnosis, for which we have as patients undergo ultrasound daily. There should be a recognizable latent phase, for which we also have, as diagnosis of short cervix occurs well before preterm birth. There should be a suitable test or examination, and this is transvaginal ultrasound. The test should be acceptable to the population, as we showed you previously in the survey. The natural history of the disease should be adequately understood. There should be a policy for treatment in each unit. The cost of case findings should be economically balanced with care, for which there are numerous studies showing cost effectiveness of this use. And the cost of case findings should be a continuing process, for which is the case for women and pregnancy. If we compare screening strategies in medicine as they are used today, we see that the use of cervical length fares very well as compared to others. For the use of a pap smear, you must screen 1,100 women to detect cervical cancer. For mammography in women over 50, that number is 543. For mammography in women between 40 and 49, you must screen over 3,000 women to diagnose breast cancer. For PSA in men to diagnose prostate cancer, you need to screen over 1,200 men. But in preterm birth and its assessment with cervical length to detect a case of preterm birth at less than 33 weeks, this number is only 357. And to prevent one case of neonatal morbidity and mortality, that number is the lowest of all these tested, listed at 218. So what about future sonographic methods to evaluate the uterine cervix for the prediction of preterm birth? We have examined the use of cervical elastography for the prediction of preterm birth. Elastography is the tissue displacement or the strain or velocity of propagation of a mechanical stimulus within the cervix as a shear wave, and it can provide information on the softness or stiffness of a cervix. The changes in elasticity are displayed in a color elastogram. This image shows a sagittal view of the cervix. The red denotes soft tissue and the blue stiffer tissue. This image displays the internal and external os, as noted. Also, the soft and stiff issues can be designated with blue and red and orange. This image depicts the elastogram overlying the cervical image. The region of interest is designated by this circle. The stiffness is noted here by this color key, and the strain ratio is noted in the upper left. The strain values are consistently higher or softer than those from the complete sagittal view from the internal cervical os. However, we know that these values converge when the cervical length is close to 30 millimeters or as a function of gestational age. In addition, there is an increased prevalence of preterm delivery at less than 37 weeks in women with a strain in the internal os more than 50th percentile for gestational age at 17 to 24 weeks. Pregnant women with strain values more than the 50th percentile in the internal cervical os have the highest risk of preterm delivery. Future studies will need to be done to evaluate its utility coupled with interventions for the prevention of preterm birth. In conclusion, sonographic cervical length is the most powerful predictor of preterm birth. The definition of a short cervix varies by obstetrical history. In patients with a short cervix in the mid-trimester, 22% have intraamniotic inflammation and 9% have interamniotic infection. The optimal time to examine the cervix is 19 to 24 weeks gestation. The correct technique for cervical length examination is critical. The cervix should be measured with an empty bladder by transvaginal ultrasound using a sagittal view. Amniotic fluid sludge increases the predictive value for preterm delivery. In women with a sonographic short cervix, vaginal progesterone decreases preterm birth and neonatal morbidity in women with a short cervix, in both singletons and twins. Cerclage reduces preterm birth in women with a prior history of preterm birth and a short cervix. The pessary has not been definitively proven to decrease preterm birth. It is of benefit for pregnant women to undergo a sonographic cervical length measurement in the mid-trimester to assess her risk for preterm birth. Thank you for your attention.